Everyone. Welcome to today's webinar on the behalf of the Renal Pathology Society Education and Training Committee. It's my pleasure to briefly introduce Dr. Ingeborg Bajema.
Yeah, good. Okay, so hello everyone, and again, thank you for the invitation to talk today on one of my favorite topics. I will give you an update on lupus nephritis. And the picture that you see is from Groningen. And this picture is actually where I am right now because I am in Edinburgh, where Silkebrix and I are going to have the first band-like meeting to update the classification for glomerulonephritis, and that's going to happen tomorrow. But meanwhile, you can have a look at my disclosures, and then I will give you a short agenda of what I'm going to talk about. This is all going to be about lupus nephritis classification, the indices for activity and chronicity. I'm going to discuss some new techniques like artificial intelligence. And on the whole, I think that the red line of my talk is how are we doing? Can we do better? And how? So first of all, lupus nephritis. I think, as you all know, the changes in the kidney biopsy of patients with lupus nephritis can be absolutely bewildering. And that is actually what this screen is trying to show you. We see here multiple glomeruli in various stainings with lots and lots of glomerular lesions. And of course, also the interstitium and the vessels can be affected by lupus nephritis. What we should keep in mind, of course, and when we think of day-to-day clinical pathology, is that I'm going to talk about the lupus nephritis classification in a minute, which essentially is a classification in which lupus nephritis is classified into different patterns. And if we see these patterns, like for instance over here, this is a mesangial pattern of disease, then we need more tests, primarily the immunofluorescent test, in order to know whether, for instance, this pattern of disease is from a patient with lupus nephritis who would typically have a full house pattern, but it could also be a pattern of disease that we see, for instance, in IgA nephropathy or even in diabetic nephropathy. It also holds for other patterns. Over here we see, for instance, crescents. They could be seen in lupus nephritis, but also, for instance, in ANCA vasculitis. And I'm just touching upon this because later on in my talk, I will return to this topic, namely that what we don't know, many of these patterns occur also in other classification systems of other diseases, like, for instance, the crescent in the MEST score. What we know very little about is whether such a lesion has the same sort of prognostic features, whether it is the same sort of lesion that would react the same to a given sort of therapy in lupus nephritis or in other diseases. And that is a very important issue, and there's very little information on that. If we focus on the glomeruli in lupus nephritis, then, as mentioned, the lesions can be really bewildering and they're very, very diverse. They can be acute, they can be chronic, they can affect the mesangial areas, the capillary loops, the extracapillary areas, and the GBM. And if you want to break down all of these lesions, which we did in several studies, then on the left side, you see a scoring form. This is a very, very extensive scoring form. Nevertheless, it is just to sort of remind you how complex the pattern of disease is in lupus nephritis. And that becomes even more complex when we realize that these lesions may vary in time. If we have more biopsies in one patient with lupus nephritis, then we can find completely different patterns. It's also important to realize that the clinical symptoms of a patient with lupus nephritis only sort of vaguely indicate what kind of lesions we're going to see in a biopsy, which makes the kidney biopsy in lupus nephritis of the utmost importance. So one important way to think about the classification is to really think of the classification as a way to break down all of these very complex lesions again into several classes. In fact, I'm almost certain this being the first classification of kidney diseases in pathology, it was exactly this point, namely when biopsies were taken more and more of patients with lupus nephritis, it was realized very soon that they were very, very different from one to another, more than in other diseases. And of course, we needed a system to indicate as a shorthand note what type of lesions do we see in this particular biopsy. And over here, this very nice overview, which is from Charles Jeanette, we see in the diagram 5 classes. There's also a class 6 lupus nephritis, which is characterized by mostly global sclerosis. But we see here the immunofluorescent pattern of all the classes. We see what we see in a capillary loop by electron microscopy. And on the bottom end, we see in these very nice drawings of a capillary loop with the podocyte in green, the mesangial cell in red, and the endothelial cell in yellow, how they are affected by the disease. And we see all of these deposits coming in. In class 1, only a few deposits in the mesangial area. In class 2, many more of them. And because we have 2 red cells over there, it means that these cells start to proliferate. Then we have deposits that may move on to be present inside of the at the subendothelial space, leading to inflammatory cells. And these are the lesions that we see in class 3 and 4, with only a cutoff level of more or less than 50% of glomeruli of the biopsy being involved in that, making a distinction. Class 5 is a very different type of lesion. This is the membranous type. And as mentioned, we can have switches from one kidney biopsy to another. We can also in one biopsy see glomeruli that would be like